can I just double check? Everybody able to see the screen? And the presentation?
Yeah.
You can see it. Okay, there we go. Great. Wonderful.
Perfect.
Perfect. Good afternoon, everybody, and a big welcome to everyone here today. It is a great honor and privilege to have a very special speaker this afternoon, but it's not going to be my job to introduce him. That I will leave to Dr. David Britton, who I'm sure is very well known to all of you. But just in a nutshell, so David is, of course, in charge of ACT Life. He's also the past president of the South African Stem Cell Transplant Society. He is an honorary lecturer at the University of Cape Town in our division, and a person who has moved and shaked and is still going forward, moving and shaking with all kinds of exciting plans with CAR T cells, etc. in South Africa. David, it's really a pleasure to introduce you today to chair this meeting. Before I hand over to David, just a few housekeeping rules or suggestions. This meeting is CPD accredited, so at the top of the hour, there should be a link in the chat box that we can use, that you can use to just register your presence. Please do not put your details in the chat, because all of what you would register later goes straight into a database that goes to the HPCSA. The recording of this video is also available afterwards on the UCT Vula website. You can contact us for information if you don't have the link. I will put the email address of Melanie Davids in the chat that you can email her for access to that. Then I just want to thank a few people, Prof. Estelle Verburg, Dr. Elzaan Jansen van Rensburg, Jani van Wyk, Melanie Davids, all of whom were part of the organizing of today's session. And then a very special thank you to MSD, who has kindly sponsored the speaker today, Professor Zanzani. And it's my great pleasure now to hand over to the chair of this meeting. I will only be co-chairing Dr. David Britton to introduce Prof. Zanzani. Thank you, David.
Thank you for that introduction, Vernon, and thank you for inviting me to chair. It really is a great privilege to introduce Professor Zanzani, who is really one of the heavyweights of lymphoma research in the world. And we're very lucky to have a man who's dedicated a lifetime to excellent service to patients, academia, and the lymphoma treating community. He is a member of a bouquet of different societies, many of whom he has or currently does serve on the executive or has been chair of. He's past president for the Italian Lymphoma Society, and he is incredibly widely published with more than 650 articles. And besides his direct involvement in research, he offers his service to review submissions for many of the major journals such as Lancet, JCO, and Blood. And this, where he finds the time to then go ahead and present at all the international meetings and congresses, over 450 of those. You know, I suppose they're time zones, and you can get a lot more done then. His current research interests include clinical trial methodology, prognostic factors in non-Hodgkin's lymphoma, and new drug development in Hodgkin's lymphoma. We really are privileged to have such a heavyweight sharing his experience and research knowledge in this rapidly evolving field of Hodgkin's lymphoma, which for many, many decades, I dare say, was pretty static. And now with the advent of immunotherapies has really been turned on its head, and we look forward to being able to dissect how to manage this group of patients who generally have a good prognosis, but when things do become problematic, they are really problematic. So without too much more of myself, thank you very much, Prof. Zinzani, and I hand the floor over to you.
Thank you very much, Professor Britten, for the kind introduction. Good afternoon for everybody, and thank you for inviting me this meeting. So in the next 40 minutes, I will try to do an update concerning the role of checkpoint inhibitors in the treatment of Hodgkin lymphoma. Next, please. Here's my disclosure. There are several issues. The first one is a single agent checkpoint inhibitors in relapsed refractory classical Hodgkin lymphoma. Good, not great. Next. And you can see here, you know very well this data concerning the phase 1 study of nivolumab and pembrolizumab. I was involved in both of these clinical study, and at the end of the day, the overall response rate and the CR rate is quite similar. So we can have a 20-25% of complete response in relapsed refractory patients with Hodgkin lymphoma, and globally the overall response rate is ranging between 60 to 80%. You can see here the waterfall plot of Nivo and Pembro together, and the tumor response is more than 90%. Next, please. And after this really interesting phase 1 data for both drugs, there was the phase 2 study. At the same time, I was involved in both of them. There was the Keynote 087 for pembrolizumab and Checkmate 205 for nivolumab. In both of these phase 2 studies, there are 3 different cohorts of patients quite similar. So I mean, for nivolumab, there was the cohort with a patient who received the prior autostem cell transplant with no brentuximab vedotin. The second cohort, autostem cell transplant and brentuximab vedotin. And the third cohort was autostem cell transplant with a sandwich treatment with brentuximab vedotin, I mean pre and post transplant. For pembrolizumab, there are 3 different cohort. A patient received autostem cell transplant and brentuximab vedotin. The second cohort was patient ineligible for autostem cell transplant. This is a real kind of difference when you compare Pembro versus Nivo in terms of phase 2 study. And the third one was autostem cell transplant without brentuximab vedotin post. So at the end of the day, you can see here that we enrolled more than 450 patients, and the overall response rate of both checkpoint inhibitor and those in particular of all the 6 different cohorts are quite similar, ranging between 65 to 75%. The same situation for the CR rate, that is ranging between 15 to 30%, and these data are absolutely the same that we observed in the phase 1 for both the checkpoint inhibitors. Next. And you can see here the waterfall plot for Keynote 087 and also for the Checkmate 205, a really impressive picture concerning the reduction of the target lesion with the checkpoint inhibitors in this setting of relapsed refractory Hodgkin lymphoma patients. Next. And of course, as you know, for both of these checkpoint inhibitors, I mean Nivo and pembrolizumab, there was official indication by FDA and also by EMA. At the same time, in China, the first checkpoint inhibitor who received the official indication was sintilimab with the study called Orient 1. And you can see here the waterfall plot. The overall response rate was 80%, the CR rate was 34%. Right now, there are other 2 checkpoint inhibitors with an official indication in China for the treatment of relapsed refractory patient with Hodgkin lymphoma. Next. And another important point is the for nivo and pembrolizumab study, phase 2 study, is the decline of duration response cure with a longer follow-up. You can see here the situation is quite similar when you compare the Checkmate 205 and the Keynote 087. Next. And I think it's important, these are, I did an update at the ASH meeting 2019 concerning the Checkmate the Keynote 087 in terms of duration response and also progression-free survival for the patient who obtain a complete metabolic response. So in terms of median duration response for all study population was not reached. And also in particular, for cohort 1 was 31 months, for cohort 2 for 33 months, it was not reached for cohort 3. The situation was quite similar also in terms of median progression-free survival that was not reached, and for all the first 2 cohorts, the median progression-free survival was ranging between 33 to 35 months, and the cohort 3 was not reached. But as you said, you can see here that there were 58 patients who received a complete metabolic response, and 38 of them had no further consolidation treatment. So I mean, no auto stem cell, no allo transplant, and the patient are in continuous complete response after the treatment with the pembrolizumab. At the same time, 14 patients had the consolidation therapy but no stem cell transplant, I mean with a conventional chemotherapy, and 6 patients had allogenic stem cell transplant consolidation. I mean, I come back to the 30 patients. So at the end of the day, it's possible potentially to cure a subset, a small subset of patients with relapsed refractory Hodgkin lymphoma only with pembrolizumab, and you have to continue the treatment for at least 2 years after the first evaluation, where you can consider the patient in complete metabolic response. Next. And as you know, 2 years ago at the EHA, and I presented at EHA this data, John Corovilla presented the same data at ASCO meeting, the phase 3 randomized open label study of pembrolizumab versus brentuximab vedotin for the treatment of relapsed refractory classic Hodgkin lymphoma. The study was called Keynote 204. Next. Next. This is the study design of the trial: relapsed refractory classical Hodgkin lymphoma, relapsed post-auto stem cell, or ineligible for auto stem cell transplant, and failed 1 prior line of therapy. Of course, miserable disease, a good performance status, and we included brentuximab vedotin naive and brentuximab vedotin exposed patients. The random was 1-to-1, comparing pembrolizumab, the conventional dose of 200 milligram flat dose intravenous every 3 weeks up to 35 cycles, and versus brentuximab vedotin at the dose of 1.8 milligram per kilogram intravenous every 3 weeks up to 35 cycles. The response was assessed according to the Chisholm criteria 2007, and at the same time, the primary endpoint was progression-free survival per blinded independent center review by the Chisholm criteria 2007, including clinical and imaging data following auto stem cell transplant or allo stem cell transplant. And the second and primary endpoint was overall survival. It's too early to have this kind of data. In terms of secondary endpoint, we included the progression-free survival per independent center review by the Chisholm criteria 2007, excluding clinical and imaging data following auto stem cell transplant or allo stem cell transplant. And also the overall response rate by independent center review, progression-free survival per investigator review, duration of the response, and also, of course, safety profile. Next. You can see here the primary endpoint was met, the progression-free survival per blinded independent center review. The median progression-free survival for pembro was 13.2 months versus only 8.3 months for brentuximab vedotin. And at 1 year, the median progression-free survival was 54% for pembro versus only 36% for brentuximab vedotin. Next. And also, if you stratify the patient, the key subgroups, the progression-free survival in all these subgroups is an advantage of pembrolizumab versus brentuximab vedotin. In particular, for patients who receive prior autostem cell transplant, patients considered primary refractory, and also for early or late relapse, and also independently by the prior brentuximab vedotin exposure. Next. In conclusion, the pembrolizumab monotherapy shows statistically significant and clinical meaningful improvement in progression-free survival versus brentuximab vedotin in this subset of patients with relapsed refractory classical Hodgkin lymphoma that have relapsed post-autostem cell transplant or are ineligible for autostem cell transplant. The primary endpoint, the progression-free survival was met, and also there was a progression-free survival benefit that was extended to other key subgroups, and there was at the same time more durable response for pembrolizumab, 65.6% versus 54% for the pembro versus only 14 months for brentuximab vedotin. The safety was consistent with the known profile of each agent. So pembrolizumab should be considered the preferred treatment option and the new standard of care for the treatment of relapsed refractory classical Hodgkin lymphoma in patients that have relapsed post-autostem cell or are ineligible for autostem cell transplant. There was official indication by FDA and also recently the official indication by EMA. Next, please. The second issue was combination therapy. The answer is the unrealized promises ? Next. And the promise. So there is some disappointing because the second step is to try to combine checkpoint inhibitors with other agents. And at the beginning, there was some disappointing because the combo nivo plus ipilimumab, the result in terms of overall response rate and in terms of CR rate was not so different when you compare with nivo as a single agent. So overall survival, overall response rate was 74%, and the CR rate was less than 20%. So there was no a synergistic activity when you combine nivo plus ipilimumab. Next. Anyway, when you combine brentuximab vedotin plus nivolumab in this case, you can see that there is a really promising result in terms of overall response rate ranging between 80 to 90%. At the same time, the CR rate was more than 60%, exactly ranging between 60 to 65%, according to the Ragnana Advani presentation, and also lastly the presentation by Alex Herrera in several different meetings. And at the end of the day, this setting, this doubled, so I mean nivo plus nivolumab plus brentuximab vedotin is really active in this setting of primary refractory or early relapse patients. And it's possible to obtain in a complete metabolic response in at least 2/3 of the patients, and you can move to consolidation with autostem cell transplant. Next. And another important combination could be pembrolizumab plus FM13. This is a bispecific CD16 and CD30, and the data were published 2 years ago by Nancy Bartlett on Blood concerning this phase 1 data, very promising data, because at the end of the day, this kind of combination, we can obtain 83% of the response rate and more than 40% of complete metabolic response. Of course, we are only at the beginning of the story, 30 patients, phase 1 study. Anyway, this kind of combination is very promising. Next. In terms of combination, I think there are interesting, again, preliminary data concerning the combination of a checkpoint inhibitor. In this case, is camrelizumab, again from China. This checkpoint inhibitor received the official indication in China, and this is a very interesting phase 2 study combining camrelizumab plus decitabine in Hodgkin lymphoma patient with a relapsed refractory situation. And you can see here that the monotherapy, these checkpoint inhibitors, camrelizumab, is quite similar to Nivo Pembo, 30% of CR and 90% of overall response rate. When you combine with the decitabine, we can really present a fantastic improvement of the CR until 71%. The overall response rate is close to 100%. So really interesting data, and this new pathway in terms of combination is to be evaluated in a second time with more patients and also with different checkpoint inhibitor. Next, please. And after that, you can have several other combination, in particular, for example, Nivo plus decitabine instead of the Chinese checkpoint inhibitor. And can we pick a winner? I think it's really difficult, but at the end of the day, potentially the best treatment could be Nivo plus brentuximab vedotin in terms of data, in terms of safety profile, and also because we treated around the world a lot of patients, so it's possible to really be quite sure. The problem is that at the end of the day, there is no official indication by FDA because there was not a trial, but in the United States it's quite easy to use this kind of combination because this was included in the NCCN guideline. It's quite impossible to use this kind of combination outside the United States. Next, please. And you can see here an update by Alison Moskowitz concerning this kind of combination in primary refractory early relapse patients. There was the consolidation with autostem cell transplant after the CR rate, complete metabolic response with brentuximab vedotin plus Nivo, and you can see here the 2-year progression for survival after consolidation with autostem cell is more than 90%, and these data are really very interesting. Next. The third point is chemosensitization. Is a real doorway. Next. So at the end of the day, when you have a patient that is resistant or refractory to every kind of line, I mean conventional chemotherapy in front line, second line of chemotherapy without after cell transplant, the role of brentuximab vedotin, the activity of checkpoint inhibitors. After that, is impossible right now to have other new drugs. We had the CAMI, the anti-CD25 drug conjugated from ADC Therapeutics, but the trial was closed. There are some problems in terms of toxicity related to the 7 cases of patients who had a Guillain-Barré syndrome. It's quite difficult to have a good CAR T cell so far for the treatment of Hodgkin lymphoma patients. And one concept could be the chemosensitization. So, I mean, if you have patients who didn't respond to other drugs, in particular brentuximab vedotin and also checkpoint inhibitors, we can retreat with conventional chemotherapy using the same agent or other new agent. And in at least 50–60% of the patient, we can obtain a complete metabolic response or a partial response. So this, I think, is important because the chemosensitization is the final result of the activity of checkpoint inhibitor on the immune system. And here you can observe There are some data. This one is from the French group. Rossi was the first that presented and published this data. They treated 30 patients with a conventional chemotherapy. And you can see here the data. The CR rate was ranging between 40% to 57%, and the overall response rate was ranging between 70% to 90%. At the end of the day, there are some patients in continuous complete response without any kind of consolidation. Also, some patients moved to auto stem cell or allo stem cell transplantation in terms of consolidation. Next. The second experience was here. Next, please. And here you can see the data from the Dana-Farber group. Caro and co-workers presented this data at the ASH meeting 3 years ago concerning the same concept of chemosensitization. Also in this case, 30 patients. It was a pool of patients. And at the end of the day, you can see here that the results are really good, in particular for patients who received also auto stem cell transplant after the achievement of complete metabolic response. Next. And this is our experience in Bologna. In the same setting of patients, we treated 25 patients again with conventional chemotherapy using bendamustine, using also other single agents that we used before in the same patients, in particular also Chelix. And you can see here, 92% of these 25 patients were refractory to the last treatment before anti-PD-1. And after a median time of roughly 2 months from the response assessment to anti-PD-1, 15 patients received a single agent treatment and 10 had a multi-agent regimen. At the end of the day, in terms of chemosensitization, the overall response rate was 60%, with 8 patients who obtained a complete metabolic response and 7 patients who obtained a partial response. And the median progression-free survival with salvage treatment was reached at 19 months, while the median progression-free survival after anti-PD-1 is reached at 8.2 months. So after a median follow-up of roughly 33 months, 6 patients died, while 13 are still alive and in continuous complete response. Next. The fourth point, I think, is very close to David, the role of allotransplant. There is a very important question mark. Is this useful? Next. So the concept is, when I have a patient who received the checkpoint inhibitor, nivo or pembrolizumab, and at the end of the day, the patient obtained a complete metabolic response or a partial metabolic response, do you think is correct? Do you think is the best way to consolidate with allogenic bone marrow transplantation? And is safe or not? There are several preliminary publications, but this one is the most important in terms of number of patients evaluated around the world. It's a retrospective observational study, including centers from Canada, from United States, from France, from Italy. Also, our data are included here, and also from Germany. You can see that Merriman published this data the last year on leukemia. And next, please. You can see here the patient characteristics. So 197 patients. The median dose of checkpoint inhibitor was 9.45, range between 1 to 74. And in terms of best response to checkpoint inhibitor, 39 patients obtained a complete metabolic response, 38 a partial response, 12% a stable disease, and 11% had a progression. And the median time from checkpoint inhibitor to day 0 of allostem cell transplant was 82 days, with a huge range from 17 to more than 1,000 days. And next, please. You can see here the progression-free survival and overall survival curves with a median follow-up of more than 2 years. So the cumulative incidence of relapse is 18%, and the progression-free survival is 68%, overall survival is 82%. Really impressive data. Next, please. So in terms of predictors of progression-free survival, we did a multivariate analysis. And at the end of the day, the factors are disease status at allostem cell transplant. So patients in a complete metabolic response or other. For the patient who was in complete metabolic response, the 2-year progression-free survival is 77%. For other, I mean partial response, stable disease, was 57%, and the P, of course, is significant. And the same important factor is the role of post-transplant cyclophosphamide. Yes or not? If you did, the 2-year progression for survival is close to 80%. If you don't use it, it's only 60%. Next, please. In terms of conclusion concerning this issue, the first question is, can allostem cell transplant be performed safely following checkpoint inhibitors? The answer is yes. Does checkpoint inhibitor impact post-allostem cell courses? There is an increase of graft-versus disease, and there is a decrease of cumulative incidence of relapse. What is the optimal transplant strategy for a patient treated with checkpoint inhibitor? Of course, the use of post-transplant cyclophosphamide. And the last question is, should checkpoint inhibitor be used as a bridge to allostem cell transplant, or should allostem cell transplant be deferred? Should at least be considered for most patients. And this is an important question mark at the end of the day, because I mean, my opinion is that if you have a patient who obtain a complete metabolic response with the checkpoint inhibitors, normally I don't use consolidation with allostem cell transplant. On the contrary, if you have a patient that after more than 15 administration of checkpoint inhibitors maintain a partial response, at this point, I prefer to consolidate with allostem cell transplant to reduce the risk of a progression. For a patient in stable disease, I don't think it's a good modality to move to allostem cell consolidation, but we can continue until the progression with checkpoint inhibitors. Next. 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 I think, okay. Yes. How is the situation now, for example, in front line for advanced stage Hodgkin lymphoma, to have a complete vision of the role of checkpoint inhibitors? As you know, there was the Echelon-1 study using brentuximab in combination with AVD, but at the same time, in the CheckMate 205, there was a cohort D where it was possible to use nivolumab for 4 administration before to start with chemoimmunotherapy, I mean nivo plus AVD for 6 cycles in untreated advanced Hodgkin lymphoma. 51 patients was involved in this trial, and the first PET evaluation was done at the end of 4 administration nivolumab as a single agent before to start with the chemoimmunotherapy. So at this PET evaluation, the CR rate was no more than 20%, and the overall response rate was roughly 60–65%. So the same data that normally I can obtain when I use a checkpoint inhibitor in a pre-treated patient with Hodgkin lymphoma. So it's quite strange, this kind of situation. Anyway, as you know, now you can back, please. Anyway, I think you can, anyway, there is an ongoing phase 3 study in the United States and in Canada comparing BV plus EVD versus Nivo plus EVD for 6 cycles in advanced Hodgkin lymphoma. You can come back to one slide, please. Okay. Another one. Again. Okay, this is front line, we'll see. Next. Okay. Pembro. Division of pembrolizumab in front line. There were some data in terms of phase 1, phase 2 study presented at ASH meeting 3 years ago by Allen and co-worker, and also published like a short report of Black 2 years ago concerning the role in advanced untreated Hodgkin lymphoma, the role of pembrolizumab as a single agent, 3 administration before to start with chemoimmunotherapy. And the data, really preliminary data, only 30 patients, really impressive, because after 3 administration of pembro, the complete metabolic response was more than 70%. So really interesting data before to move to conventional chemotherapy. On the basis of this data, there was this phase 2 adapted study conducted in the last few months. The study was closed 2 weeks ago. I was involved in the study, again in untreated advanced Hodgkin lymphoma. 3 cycles of pembro at the conventional dose of 200 milligram flat dose every 3 weeks. There was a PET evaluation, and if the patients, and then 2 cycles of EVD without pembro. And for the patients, after these 2 cycles of EVD, who obtain a PET negativity, there are other 4 cycles of EVD, and then for the patient in complete metabolic response, there is 4 cycles of pembro monotherapy. This is another new concept, the sandwich treatment in untreated advanced Hodgkin lymphoma. Checkpoint inhibitor, chemotherapy, checkpoint inhibitor. I mean, pembro, EVD, pembro. Next, please. Okay, next. The last issue, news with pembrolizumab. Preliminary, but really interesting data. Next. These are the data that I said before concerning the new PET-adapted phase 2 study. You can see here pembrolizumab for 3 cycles, 30 patients, phase 1 study, untreated advanced patients, and then 2 cycles of EVD for the patients who are PET negative, and then other 2 4 cycles of EVD, and then end of the treatment. And this data, on the basis of this data, we decide to move to the PET, to the phase 2 PET adapted. Next, please. And you can see here the data I said before. The 19 out of 30.
Sorry, Professor Nzani.
Yeah?
It seems like there's a recording playing over your speaking. Can you hear that?
No?
Can anybody else hear it, or is it just me?
I hear only Prof speaking on this side.
Okay.
Okay,
Prof,
you can
please
move
continue.
next.
Please continue, that's fine.
And in this case, you can see near complete metabolic response plus complete metabolic response was observed in 19 patients out of 30 patients treated with 3 administration of pembrolizumab. Next, please. These are the overall survival, progression-free survival, 100%. Of course, the median follow-up is not so long, but it's close to 3 years. Next, please. And the last data presented at ASH meeting 2 years ago by Alison Moskowitz from Memorial Sloan Kettering and published the last year is a phase 2 study of pembrolizumab plus GVD as a second-line therapy for relapsed refractory classical Hodgkin lymphoma. Next, please. And this data are really interesting because it's gemcitabine plus vinorelbine plus an anthracycline, liposomal anthracycline is a Chelix. And this is a particular chemotherapy quite similar to the VEGF regimen that normally we are using in Italy. Anyway, the concept is quite similar to Nivo plus brentuximab vedotin. In this case, is pembro plus chemotherapy with the new agent comparing the agent used in front line. So you can see here the study schema, gemcitabine, vinorelbine, and liposomal doxorubicin Chelix, at least for 4 cycles, and then consolidation with outer stem cell transplant using pembrolizumab, 1 cycle, 1 administration for each cycle. Next, please. There was the PET evaluation after 2 and after 4 cycles before the outer stem cell transplantation. Next, please. And you can see, and it was possible also for patients who obtain a complete metabolic response after 2 cycles to move directly to consolidation with outer stem cell transplant. Next. Next. Next, 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 next. Okay, next. Okay, so the preliminary data, only 39 patients. Anyway, after 2 cycles of pembro plus GVD, so the evaluation was done at this point with on 37 patients. The CR rate was 92%, and the overall response rate was 100%. Really impressive data. So you have to remember that with brentuximab plus Nivo, the CR rate was ranging between 60 to 65%. And the data of, for example, brentuximab plus bendamustine by Anne Lacache from the Dana-Farber was no more than 70%, 75%. So this data are really impressive, and potentially we can stop the treatment after 2 cycles of pembro plus GVD and then move directly to outer stem cell transplantation as a consolidation. Or another potential opportunity could be to conclude the 4 cycle of this chemoimmunotherapy without any kind of consolidation. We'll see in the future. Thank you very much for your attention.
Sure, thank you, Prof. That's a lot to digest in a very short period of time. I'm just going to check on the chat book. Dr. McDonald's asking, he's saying, I know there's no head-to-head data, but would you like to comment on the alternative dosing of 400 milligrams every 6 weeks versus 200 milligrams every 3 weeks in relapsed refractory disease?
Yeah, I started to use this new doses and schedule of pembrolizumab. The activity is absolutely the same. Normally, I'm using because I see patients from 12 different regions in Italy, and if the patient comes from a really far city, it's easier also for the patient, for the caregiver. The activity and the safety profile is absolutely the same.
Yeah. Can I ask you a question? Is there some way to identify patients earlier that are going to fail I mean, besides the sort of the traditional, just high bulk, high risk disease? Are there any other markers that will say this is a patient that one should strongly recommend using a PD-1 inhibitor in, as opposed to a chemo conjugate?
So I mean, it's difficult. So I treated in my institution, including Nivo and Pembro, more than 350 patients in the phase 1 study, phase 2, and also in the real life. Anyway, it's so difficult to have this kind of biomarkers. I mean, in my personal experience, when you have a patient who obtain a complete metabolic response after 4, no more 8 cycle of checkpoint inhibitors, this is a very real important biomarkers. In this setting of patients, you can really avoid the consolidation with allostem cell transplant, as I said before. In my experience, outside clinical trial, I have at least more than 15 patients with this in this situation, and I stopped the treatment after 2 years of pembrolizumab or Nivo, and now they are all in continuous complete response without any kind of consolidation. So this is the demonstration that potentially we can cure a small subset of patients. But the same data you can observe in the Keynote 087. As I said before, there are 38 patients that after more than 3 years were in complete metabolic response. And now with Philippe Armand, we are close to define and conclude the final manuscript with an update at 4 years of Keynote 087. The data are really impressive.
Yeah, that is very good. You know, your comment about post-transplant cyclophosphamide for the allotransplants giving you a better result made me wonder, have you got any experience in haploidentical transplants in this setting post PD-1 inhibitor, and do you think that the GVHD risk is, you know, is the same as with the other types of transplants?
I think absolutely. And but this was an unbelievable prognostic factors in our hands. So this was a multivariate analysis on more than 190 patients. It was a really large amount of patients, but it's really impressive, this data.
Yeah, I mean, we you know, are obliged often to use haploidentical donors just because we don't always have match-related family members for a variety of reasons. But you know, we quite commonly are seeing the patients when they start, they get a little bit of this kind of generalized aches and pains, maybe a little bit of fever here and there, and gastrointestinal upset. And then
you have to continue.
It usually settles down. But how often do you see sort of frank autoimmune problems? Like currently we have a brisk autoimmune hemolytic anemia patient who's after his first cycle of first dose of 400 milligrams of Pembro.
Yeah, this could be a problem. Is a rare situation anyway. You have to stop the treatment, to use, of course, steroids, but at the end of the day, you can restart with the treatment.
Okay.
So in my experience, I had a complete discontinuation of Pembro Nivo only in no more than 3-4 patients, and in this situation was related to transaminitis, autoimmune transaminitis, and in 2 cases was related to autoimmune hepatic toxicity, which is really terrible. But in the majority of the patient, you can restart without any kind of problem.
Yeah. I thought it was particularly interesting, your comment on re-challenging patients with chemotherapy. So patients, are you saying that patients who've had chemotherapy, failed, then have been salvaged with PD-1 inhibitors and then relapsed, that those patients may relapse, may respond again to
Sure.
chemotherapy? And what is
Patients
the mechanism?
who did bendamustine in the past, in the prior regimen, they showed they were refractory or non-responder to bendamustine, for example. And after the chemosensitization after the treatment with checkpoint inhibitor, and then I did the chemosensitization with bendamustine, there was a response. Also, in some patients, a complete metabolic response.
And do you think that's a microenvironment issue, or do you think it's a direct?
Potentially, yes, but it's not really clear the situation. I discussed it several times also with Philippe Armand, with Stephen Ansel about that, but it's not clear. Probably there are several mechanisms of action, but the situation is absolutely unbelievable, because in our experience from French and also from several American centers, is really unbelievable, because you can obtain in at least 50–60% at least a partial response, and then you can decide what to do. You can consolidate with allo or without, because at the end of the day, there are a percentage of multi-relapsed or refractory patients with Hodgkin lymphoma that you don't know what to do, because you did everything: chemotherapy, second line, auto stem cell, brentuximab, checkpoint inhibitors, and then so far right now there are no new trial in Hodgkin lymphoma with new agent. We are waiting for CAR T-cell, but it's like a dream so far, CAR T-cell in Hodgkin lymphoma.
Can I ask you, just for some of the audience who have less experience in allogeneic transplantation, just to discuss the rationale of post-transplant cyclophosphamide and the timing, the dosing and the timing of it, and why do we use it?
Well, the classical one in terms of dose and time, the classical one, but at the end of the day, we don't know really, because this was a retrospective observational study, including more than 18 different centers in United States, Canada, and 3 countries in Europe. And according to the different centers, there was a different modality to do allogeneic cell transplant. And at the end of the day, 60% of patients did cyclophosphamide post-transplant, 40% no, and there was this kind of difference in our multivariate analysis. But nobody knows so far which is the concept, which is why this kind of situation in terms of better curve when you use post-transplant cycle instead of not.
I always understood that the post-transplant cyclophosphamide gave you quite good, or rather very good, acute graft versus host disease control, but still left some chronic graft versus host disease. And maybe in that situation,
potentially yes, David. But at the end of the day, we have also some patients in our institution that didn't, and that they are in continuous complete response after more than 2 years.
Yeah.
It's not black and white.
No. Okay.
David?
I don't know if there are any other questions. Vernon, you want to make a comment?
Yeah, no, thank you very much, Prof. Zanzani, for a very interesting talk. I want to ask you about the short, medium, and longer term effects of PD-1 inhibition on the rest of your immune system. And firstly, whether you found that the GVHD that you see post-transplant is more refractory or less refractory than typical GVHD. So is the responsiveness to ruxolitinib, for instance, changed in any way? And second, if you look at things like CMV reactivation and other infections, fungal infections, etc., have you found that there's a change post-PD-1, if you've been given PD-1 inhibition prior to transplant, that you have more infections afterwards?
I start with the last part of your questions. We didn't observe more fungal infection or CMV reactivation in patient pre-treated with checkpoint inhibitor before allotransplant. In terms of GVHD, there was a small improvement of GVHD, in particular acute GVHD, but it was possible to control in the majority of the patients. Was not a real problem. The real problem of GVHD improvement is related when you use nivo pembro after auto stem cell transplant. If you remember, at least 3 years ago, there was in the same issue of blood, 2 experience, one from French, another one from United States, concerning patient who did allo stem cell transplant, and also there's in some patients they received also before allo stem cell transplant checkpoint inhibitors, and in the case of the relapse after allo, the patient received checkpoint inhibitors. So the results were quite unbelievable in terms of clinical response, more than 50–60% of a complete response. The real problem was graft-versus-host disease, the acute one, more than 60%, and was a real problem in terms of some patient died, and so on. But there is no this kind of problem when you use checkpoint inhibitors before allotransplant. At the end of the day, is quite easy. Of course, we can observe a major number of graft-versus-host disease, in particular acute, in patients who received allotransplant in the status of partial response when you compare with complete response.
Thank you very much. And maybe another question to add to that: do you see an improved outcome in patients who have more severe autoimmune complications? That the Hodgkins respond better if there's more autoimmunity, or let's say immune type adverse events?
I don't know. I didn't check this. Interesting. I didn't check. I will try to come back to my series and to see. It could be interesting. Could be really interesting, this one. Thank you for this opportunity. We'll see.
It's a pleasure. Just to quickly say, while David is thinking of another comment or question, I have put the link in the chat box for CPD registration. Please click on that if you need CPD points. And yeah, if anybody else obviously wants to use this great opportunity to ask questions, the time is now.
I think you've certainly exhausted my limited knowledge of PD-1 inhibitors. And I must say that it's been a real privilege to share such a depth of experience and knowledge. You know, it's not a few patients that have been through your clinic and your trials with these issues. And you sort of answered the big question is, what is next? And you know, with the Hodgkin's lymphoma, do you think it'll be the problem with the CD30 CAR T is that it's going to attack the T cells, isn't it? And that's the real problem with using a new next generation or Hodgkin's type CAR T cell.
Yeah, concerning CAR T cells for Hodgkin lymphoma, there is a small biotech in the United States called Tessa. Potentially, they did a phase 1 study in the United States, and the preliminary data are quite interesting because everything started with I don't know if you know the data from Ramos Carlos from Baylor College in Houston, where the data concerning this kind of products are quite interesting, but really preliminary. They treated more than 15–20 patients. The CR rate is roughly 47–50%. And the problem that is you have to try to do a trial with more patients, and now this company try to start probably in the next 6 months with a real international study concerning the role of CAR T-cell in the setting of relapsed refractory patient with Hodgkin lymphoma. At the same time, there is an academic center in Spain, in Barcelona. They produce anti-CD30 products, CAR T-cell for Hodgkin lymphoma. They did the phase 1 study with a really preliminary interesting data presented at the last European meeting of hematology in Vienna. But we'll see. So for sure, for our patients, at least for this kind of 10-15% that continue to be resistant or relapsed after more than 7, 8, 9 lines of treatment, we need CAR T-cell. But at this point, if you have an active product for CAR T-cell, for sure we have to move as soon as possible from the right to the left to reduce the risk of treated the patient, but we'll see. First of all, we need CAR T-cell, good product for CAR T-cell, and then we can change a little bit the study schema for our patients with Hodgkin lymphoma.
Prof. Zanzani, do you ever use palliative radiotherapy still in patients refractory to everything?
Yes, of course. Palliative treatment, local radiotherapy could be one choice for palliative treatment. There are also some some data concerning the role of, in terms of synergistic activity between radiotherapy and checkpoint inhibitors. In fact, there is an ongoing phase 2 study at Memorial Sloan Kettering using this kind of combination for early stage Hodgkin lymphoma.
I just wanted to ask you if radiotherapy could sensitize the lymphoma cells in some way to
yes. There
PD-1
are some
inhibition.
preclinical data concerning that. Absolutely.
Great.
Yeah. Good stuff.
That's really interesting. David,
Yeah.
I think if you are good,
Right.
we can close up.
Yeah, I think we can do that. So as I said earlier, thank you very much, Prof, for sharing your vast experience, and keep up the good work. And we look forward to hosting you in person at one of our local conferences soon, if not to see you at one of the big international meetings.
Sure. I hope the same.
Great.
How is the situation right now in South Africa for the COVID-19?
What's that? As you can see, we're not wearing masks on this meeting today.
Okay. Because the situation in Europe now is coming again, so it's terrible. It's so difficult.
Yeah, I think it remains a problem for our patients who are immune compromised. But thing is, in the
change a little bit our modality of treatment. We reduce the role of maintenance treatment with the rituximab. We try to reduce also bendamustine containing regimen and so on. So, but this,
yeah, I mean, since December, the disproportionate number of patients at our center that have had COVID have been from this practice. So, you know, and especially when you look at the sicker patients, it's been more our patients than, you know, patients from outside.
Yeah.
And nearly always people with comorbidities. So I think it's here to stay. It's going to continue to be a problem for patients that are immune compromised. But in terms of the general population, it seems that between immunity and viral passaging, the virulence seems to be lower, and life's getting back to normal, I suppose.
Yeah, we hope. Okay, thank you very
Great.
much.
I just want to
Thank
say
you.
a big thank you
Thank you.
from my side as well. Again, just a reminder, CPD registration link in the chat box. Thank you to Prof. Verburg, Jani van Wyk, Elzaan, Janse van Rensburg, Melanie Davids, who all helped to make this possible. Thank you, MSD, for kindly sponsoring Prof. Zanzani's talk. And in closing, Prof. Zanzani, thank you for what you are doing for patients all over the world. It's a privilege to not only read what you do, but also being able to apply all the lessons that you've brought us over the years. And we really appreciate that. Thank you.
Thank you very much. Thank you.
Bye-bye, everybody. Have a wonderful afternoon.
Take care. Bye.